I would recommend read these books because you put it in the backdrop of doing some of this stuff. It's really helpful. And I found also that what I learned is that I probably made maybe a little bit more difference than I thought, because maybe these people now would look at a female in Iraq and understand that it doesn't make any difference in their social economic. It doesn't make any difference on their gender. We take care of those patients, or we should at least. And it also made me think, Dumbledore said in The Lord of the Rings to Frodo, we're all allotted a certain amount of time. It's what you do with the time allotted you. And I think that's something that we need to kind of remember, and we can forget about it. So here's the challenge. Okay, so some of you say, well, I just can't do those kinds of mission trips. Well, they don't have to be elsewhere. They can be right here. So this is a patient, and these are contemporary. So this is a patient who I saw right before I went to Vietnam. And he's a gentleman that's unfunded, and he had a little lesion on his face. And he had no funding, so he bounced around until he finally landed in our emergency center. Now, the good thing in San Antonio is that if you're a county resident, you can have any condition, pre-existing, there's no exit clause, and we can take care of you. But if this patient had been taken care of and instead of somebody looking the other direction or punting them to another emergency center, I wouldn't have had to do what I had to do. And here's a CT scan, and I mean, this would have been much easier to take care of earlier on. It's going right up towards foraminal valley. We have to do a craniofacial resection. We actually got clear margins. I don't have any illusions that I've cured this guy, but with head and neck cancer, you can go a long time absolutely miserable, and this would have just turned into a big fungating mass between his shoulders with a trach in the middle of it and a feeding tube in his stomach, and he'd have died a couple years later. And so there he is on post-op day 1, and he's done actually very well. But it raises the question. That is the question of preserving our missions in medicine. So one is, why do we have this kind of problem? Why is it that we have these patients that we can't take care of? And is this situation that we're facing in the United States likely to get better or likely to get worse? I don't think it's going away. Why is it that we find it's easier for us to provide care somewhere else, but we have trouble taking care of that indigent patient here? That we can send them off, but we can run off to some other country for an exotic vacation and take care of them. What are the collateral risks? What are we teaching these medical students? What are we teaching the residents? What are the behaviors that we model as we do this? Are we recalibrating our ethics? And what is this going to mean to our profession? And then what can we do? And these are just the beginning of the questions. It calls the question, is our mission in medicine really for caring for patients, the teaching and the research, or is it being redefined? Caring for patients when they're funded, teaching when it doesn't interfere with my productivity. I find it really challenging working with medical students now because they're being marginalized. I'm on the electronic medical record trying to do the coding and all the other stuff. They can't write notes. So they have, they can sit and do medical school by correspondence, almost sitting in the back. And I tell them, man, they have to be proactive because they're going to take care of me one day, and I want them to know what the hell they're doing. And you can't just sit back there and take it casually. And but there's a very active, subversive marginalization, I think, that occurs in medical student education that if we don't get in front of, it's going to be a real problem. And then research. Everybody knows the NIH funding things, and so maybe we do research as long as it's politically correct or well-funded. So how do we preserve the missions in medicine? And I think it starts first with water that seed that needs to germinate so that you can understand your professional growth and personal growth in a new way. If you want to get into, I know I'm trying to keep us on time here, so I'm not going to run over, I promise. If you look at things from the business, one of the ways that they do is they look at the SWOT analysis, strengths, weaknesses, opportunities, and threats. And I've actually spent a little bit of time looking at this, and I've visited other countries, UK, Australia, a variety of places looking at healthcare in different areas. And and that variability factor. And you know, I would argue that we really do have one of the best healthcare systems in the world. Now, you can use infant mortalities, and I know sometimes that data gets skewed because what they use is they use infant mortalities, but they don't count the preemies or the ones, there's all kinds of different ways that you can bend the statistics. Weaknesses. What we have is we're challenged. If you go to the UK and you're 65 years old and you're diagnosed with a cancer, they've matched expectations with reality. The patient says, okay, I'm 65 years old, time for hospice. Our patients, they say 65 years old, I've got a cancer, do everything you can. So matching expectations with reality, I think, is a real important thing. We have opportunities of endless possibilities, bright minds, interconnected in ways that we've never been, but we have a real threat, and that is we have an unsustainable financial model. And I think that that's just in the backdrop of a lot of other changes that are occurring where it was mentioned earlier, we're becoming employees instead of practitioners. And, good and bad things with duty hours. One is it sort of changes us into shift workers. And there's a lot of things that, we need to think about. We have a real serious demographic issue. I'm part of the baby boomers. And, the number of worker bees coming up to support us is much fewer. I tried to get a sense of what a trillion was. I knew it was one with 12 zeros, but that honestly didn't mean anything. I haven't bought anything that costs $1 trillion yet. So I thought it was astronomical, so I thought I'd try to put it in the context of that. And it turns out that in 31,546 years is 1 trillion seconds. It turns out 4 trillion is how many miles there are in a light year. So we've got this huge deficit, federally. I was actually just in Greece recently, and they've got, some serious issues there. Are we facing some of those things in the future? I don't know. But I think we need to start really thinking about this, and I think we can do some things. One is we need to address the fiscal realities, but remember our stakes in the ground and pursue those relentlessly. The quality patient care and the quality education. Be mindful of what I think is a fact. When financial pressures mount, values are often the first to be compromised. You can see it right now. What are we doing on budgets? We're cutting education. What's the last thing you want to do is cut? And I'm not talking about medical school education. I'm talking about education across the country. That's, school teachers. If you haven't heard of the clinical safety and effectiveness, it's Brent James on Intermountain Health. And when I was asked to go to this, I thought, great, another business course. And I have to say it was probably one of the best courses of anything that I've learned. And fundamentally, it gets to this. Variability. So there's bandwidths of quality of care. And you go to Guatemala, there's just no care. You go to Vietnam, the bandwidth is really wide. They're good in some areas and horrible in other areas. You come to the United States, and the bandwidth is actually much smaller. Not perfect, but you'll see that the bandwidth is much smaller, but we have room for improvement. Example that they use in the course is for the urologist. And this is actually a study that they did. They've been doing it for over 25 years, but they had one group of urologists that was taking 4 hours to do a prostatectomy, another one that would do it in an hour. And they both got the same amount of tissue, the same complication rate, so what was the difference? Well, one, it was a lot more expensive to do somebody in 4 hours versus 1 hour. Well, the ones that were taking 4 hours, fundamentally what they were doing was, they were going slow all over, where the ones that were going fast in the center and being careful on the capsule of the prostate. And so in a very short period of time, we don't have to study to death. You can start to understand where the bottlenecks are and reduce that variability. And by doing that, you actually get savings, real dollar savings and improvement without compromising quality. In fact, you improve the quality. And, part of what we do, it's like, Henry Ford. When they first made cars, they were individual made vehicles, and they were incredibly expensive, and they went one by one by one. And then, actually, a person named Taylor, but Henry Ford made the sort of really brought it in, is the product line kinds of things. And what they did is they made it available for everybody at a substantially reduced cost. Well, we're not making automobiles. We have an art, but we also have things that can be improved by a standardization process. And so, if I were going to make a recommendation, if you ever get an opportunity, take that course, and I'll pay for your course if you don't find it was worthwhile. You can write that down. But I think it's a tool. It puts a tool in our toolbox that if we don't have, other people are going to make the decisions for us. You need to become active versus passive in this process. And as you do so, you need to put the patients and the profession up front versus your pocket and your personal interest. And, anybody can see that. When you're having conversations and it's all around economics, it stinks for miles. So, if you put really the issues that are really important up front, people will respect that. And I think our profession is being undermined. And if we don't start doing this, every one of us, I think we're going to be, I think we get what we deserve then. Don't abandon those patients without resources. Don't turn the other way. I didn't turn the other way on this lady in Iraq, and there was much more risk. It takes a little bit of time sometimes to take. There's no doubt there's hassles with taking care of the unfunded. In some parts we can't do. We're not a hospital. We're not an imaging center. But where you can, do something. And remember the passion, the reason that we came to medical school, what we came here for, and don't let the bureaucracies and all let us start to justify behaviors that really are not appropriate. So there's my Sermon on the Mound, and thank you very much.
Stand for a few
I'm on
questions.
time.